David, did you turn the script on? I don't see that button anymore. Thank you.
Yep.
Should we get started, David?
All right, yeah, I just let one more person in and I think we should go ahead and get started.
Great, thanks for joining us, everyone, this morning. My name is Michelle Probert. I use she, her pronouns. I am the MaineCare director. And I am briefly just going to run through some of the, or all of the MaineCare team that is on the call this morning. I would let them introduce themselves, but I'm very sensitive to leaving the vast majority of time here for folks to speak. So if my team could wave their hands when I say who you are, David Jorgensen is our Director of Data Analytics, which includes the rate setting unit. And then within analytics and rate setting, we have Peter Crouch, who is our rate setting manager. We have Mandy Lee, who's a rate setting coordinator. And I might get titles wrong, but Brian Lumbra and Jessica Levesque are, I'm going to say rate setting analysts. I'm sorry if that's not the totally proper title. Then we have Jenny Patterson, who is our Director of Policy within MaineCare, and Eric Isley, our Director of Communications and Planning. I think that is the core group. So this is an exciting moment for us as we are working to implement what was LD 1867 is now Public Law 2021, Chapter 639. And the objective of a number of efforts the department and MaineCare have engaged in over the past few years have really been to get us to a place where we can say that MaineCare rates of reimbursement for our covered services are equitable, adequate, data-driven, and that we also have a system to keep those rates sustainable over time, and that the way we reimburse for services is in alignment with ensuring quality of care provision and high-value care, generally speaking. Mandy, if you or whoever is sharing the screen, you can start with the slides. So as an agenda today, I'm going to give as brief an overview as I can. Then David will describe how we are going to go through the comments section today. We will have public comment and then go through closing. So that is the next slide, Mandy, which is the agenda. And then the next slide is Chapter 639, which I just mentioned in terms of our highest level objectives. And I did want to include this slide to show the specific pieces of Chapter 639 that talk about the process that we are going through right now. So some of you participated a couple of weeks ago or attended our inaugural meeting of our technical advisory panel. And per Chapter 639, we needed to receive consultation from what we called the TAP on our recommendations for rate determination schedule. We've had that consultation. Last week, we shared our proposed schedule to the department's website. It'll come up on a slide later, but excited to have a friendly URL, which is mainecare.gov/ I think it's rate reform. David, did I get that right?
Yes, mainecare.gov/rate reform, and it's rate-reform.
Rate-reform, that's what I messed up. Okay, thank you. Today is the public forum. We will be providing a summary of comments following this forum on our again, on that website that David just mentioned. And then Chapter 639 also notes that the department does have the ability to conduct rate determinations that are not called out on the schedule as well. All right, next slide. So this is basically the same steps that I just called out from Chapter 639. It shows where we are in the progress. We have a MaineCare Advisory Committee meeting on November 1st, which is next week, where our rate subcommittee, which is also called out as a requirement under Chapter 639, can present any recommendations to the MAC at that time regarding this schedule. We, as we will repeat again later, are asking that written comments be submitted, that you all and other stakeholders submit written comments by November 9th. We are looking at the week of November 21st to post a summary of those comments. And then we are looking at early December to finalize this schedule, and we'll post it at that time. I wanted on the next slide to talk a little bit about our goals with the rate determination schedule. If you've read Chapter 639, and if you haven't, I do recommend that you take some time to do so, because it is a very comprehensive outline of our principles and process for ensuring that rates, as I said, are adequate and equitable and data-driven. What the Chapter 639 does not explicitly call out is the fact that, I think as everybody on this call probably knows, not all of our services are at what we would consider baseline from the perspective of the requirements of Chapter 639. So in other words, in order to get to that place where rates are adequate and equitable and data-driven, we need to get through all of our services first, and then we can get to that happy place that we're all really excited about, where we have regular schedule of adjustments for cost of living, and when our benchmark rates get updated, and when we have regular schedules for conducting rate studies when those are needed. So we really want to get through all of our sections of policy to baseline, and then get into that regular updating schedule. We also, the way that our MaineCare benefits manual sections of policy are set up, sometimes there are very similar services that cross different sections of policy. And for one section of policy, it really might be that that's really the kind of service that's in that entire section, and then it might be a small component of another section. But because we want to be consistent and equitable in how we and what we reimburse for services, even if they cross sections, we try to group like services together at one time, even if we go across many sections. And that can be more time consuming, and there's a lot more rulemaking and federal authority we need to get through in order to make that happen, but we believe it is best practice. And so that is something we've kept in mind, both with efforts to date and planned efforts. Okay, next slide. So I'm not going to read through this slide, but the department did not wait until the passage of Chapter 639 before we initiated our rate reform efforts. We started off early in 2020 with looking to see what our existing resources were to make data-driven rate adjustments in areas of need. And we also, at the same time, were conducting our rate system evaluation. So this is just a list of where we have already implemented rate adjustments following very close to, not exactly in all cases, because again, a number of these were before Chapter 639 existed, but where we took a data-driven approach to updating rates for MaineCare covered services. Okay, so we've already achieved a fair amount that we are proud of. In terms of the schedule, the Chapter 639 calls out that we shall put forth a schedule on an annual basis. We, as part of this schedule, are looking at rate determinations that will be initiated prior to the end of calendar year 2023. Because of the time it took for Chapter 639 to become formal law, and for us to set up our technical advisory panel and had the consultation that was required by that panel. We're getting started on this a little bit later than we would have ideally liked to. So for a year from now, we hope that we'll be a couple months ahead of where we are now in terms of an annual schedule for getting this information. But we had some extra steps given that Chapter 639 is just getting kicked off. So as we look at our proposed schedule, there are three main categories of the services that are on that schedule. One are areas where we are already required to act due to legislation that passed or budget initiatives that passed. So that is a category where we don't really have a choice. It needs to be on the schedule because it's already law that we have to take action for those services. A second category is there are services where we have made public commitments to reforming how we pay for services in certain sections of the MaineCare Benefits Manual before Chapter 639 became law. So we take public commitments seriously. And so from our perspective, we feel we need to stick to our promises in terms of what we have said that we were going to address. And then the third bucket is other recommendations. And I will just say that it's hard. It's hard to figure out like what order do we go in. So that is in part why we look forward to hearing your comments today. All right, next slide. So this is just a brief list of that last category. So the last category, again, is where we're not bound by law, or excuse me, the other categories are where we're bound by law or where we've made public commitments. And this is where we have the most discretion. These are the services that we're recommending that don't fall into those first two categories. And next slide. So I did want to call out that for those of you who have already looked through or listened to the presentation that we provided to the technical advisory panel a couple of weeks ago regarding these recommendations, we have taken off a couple of recommended rate determinations from the schedule. These were for some of our home and community-based services, waivers, and to provide a bit of rationale, the first sub-service here was really Section 21 agency home supports. There have been discussions over the past few months regarding sleep staff within those services. And there was acknowledged between providers and the department that there was a disconnect in how sleep staff currently function within those programs. And there's been a commitment for us to support programs as they're currently organized so that we can make sure that those services stay in place. If we were to conduct a study right now to account for sleep staff, it is likely, based on our current understanding, that the recommendation would be for lower reimbursement rates, because our understanding is that whether through stipends or wages or other means, sleep staff are oftentimes reimbursed less than other staff. And we also understand that many providers report those staff as part of their required staffing ratios. Due to the American Rescue Plan and the HCBS Section 9817, we cannot reduce rates right now, even if we wanted to. And that requirement stays in place through the end of March. So because we think that these would very potentially result in proposed rate decreases, and we cannot implement such a recommendation at this time, we are taking this off as a priority in the schedule. And then second, I will share that shared living rates. Prior to the pandemic, the department only would pay for a single person in a shared living arrangement, we were able to utilize Appendix K authority that was specific to the pandemic in order to pay additional reimbursement when multiple people were in the same shared living arrangement. And we want to continue that past the pandemic in order to make sure that those rates for multiple people situations don't expire when the public health emergency ends and the Appendix K authority goes away. We do not have the luxury of conducting a full rate study for these services. So our intent is to continue the multiple person rates that are currently in place under that Appendix K authority. So we are not going to be doing a rate determination. We are going to just be continuing current rates. So we are taking that off the schedule. Because we utilized pandemic authority, we still have to go through rulemaking and regular waiver amendments to keep those same rates in place. Next slide. So apologies that some of your heads may be swimming and you might be like, what is she talking about? So if that is the case, here is the website again, mainecare.gov/rate-reform. If you have questions about why we're making recommendations, this website is a great place to go for looking at our past rate system evaluation and looking at that technical advisory panel presentation where we talk about descriptions of services, recent rate adjustments that have been substantive, our rationale for prioritization, what we have done so far, and services that we have not recommended be on the schedule through calendar year 2023. So please check that out as you prepare your written comments. All right, I will stop and look to David to kick off the public comment. Thank you.
Thank you, Michelle. And thanks everyone for joining today. As a reminder, I am David Jorgensen, Director of Data Analytics and Rate Setting, and Amanda Lee is the backup co-host today who will take over if I have any technical difficulties. So before we begin the comments process, I just want to explain a few details about the process, including how you will be able to submit a comment during this portion of the meeting. So first, right now, all participants are in listen-only mode and your chat function has been disabled. Participants can only send a direct message to the co-hosts. However, please know that I myself am not closely monitoring the chat, so I may not get to you immediately. So if you do want to use the chat, please send any messages to Amanda as well. In order to make a comment on the proposed schedule, please raise your virtual hand during the comment process, and we will call on individuals in the order that hands are raised. Internet users will use the raise hand function by either selecting participants or reactions from the meeting controls at the bottom of your screen, and then selecting raise hand from the several options that appear inside the participants panel. Or you can also raise and lower your hand by pressing Alt-Y on your computer's keyboard. If you're a telephone user, you can raise your hand by pressing *9 on the keypad of your phone. Please leave your hand raised until such time as you are called on to give your comment. When the comment period begins, we will call the name or telephone number of a participant and will simultaneously request that you unmute your line, which will appear for internet users as a visual prompt on your screen. For telephone users, a recorded voice in your telephone will prompt you to unmute your line by pressing *6 on your keypad. Once unmuted, please begin your comment by stating your first and last name, your title, and the organization you represent, or your affiliation to MaineCare. Please keep your comments to 3 minutes to give others the opportunity to speak. And at the conclusion of your comment, please lower your hand. Just a reminder, this forum is in its entirety being recorded via Zoom. So when the forum is complete, we will transcribe all comments and save the recorded event via a secure server. We would appreciate any written feedback that you have following the forum to be sent within the next 2 weeks, again, by the end of the day on November 9. And with that, we will start the comment period, and you are welcome to raise your hands if you have comments to submit. All right, so first we have Joe.
Hello there, can you hear me?
Yes, thank you.
Okay, hi. Well, first I want to salute you on the endeavor. It's not an easy thing. I confess I think I'm the grandfather in the field here, having been the CEO of one BFLI and Bancroft for the past 40 years. So I have some insights that, I will share in written comment about just some of the history, because without understanding the history, it is hard to get how we got to where we are. I was looking over the site. I was interested particularly in the fact that it was identified that Section 21 and case management were what were called high outliers. And just wanted to share a few things, because I've done analysis over the years, and I just wanted to mention a few things. First, I don't know if we take into consideration minimum wage in different states, mandates that happen, but sometimes our costs went up because we were required to pay 125% of the minimum wage, which is beyond, say, Pennsylvania's at $7 an hour. So in other words, a high anomaly could be for a reason besides us being wasteful. So I did want to mention that. The other issue, I don't know if it's factored in, is there's been a massive increase of requirements for documentation with both case management and with shared living. So for instance, when HCBS came into focus here, I actually wrote the first white paper on shared living, and I know you guys are now looking at a second. Well, back in the day, we did a second, we did a third, we even did a fourth in shared living, and we tiered the funds accordingly so that there were savings for the state, but the provider also was compensated for the additional work. So it looks like we're heading full circle and doing this again, and I think that's great. But one of the things I want to mention about shared living, say for instance, with respect to HCBS, the basic foundational assumption was that we were going to do something different than had been done before. This came out of a pilot study that we did at Kencrest Services down in Pennsylvania back in 1980, where we approached the feds and we said, we think there's a more therapeutic model where we could take family and actually, reimburse them to support folks, okay, in the most optimal environment, the family, as opposed to a 6-bed, a 10-bed, a 12-bed. And the point was, there was going to be a trade-off. Things were going to be simpler, less regulated, okay, but there were going to be savings, and it was going to be the therapeutic environment. Well, say for instance with HCBS, what we just went through, I mean, everyone from my human resource coordinator to everyone was all hands on deck, slam dunk, oh my God, because they looked at us as if every one of our sites was an assisted living facility. And we need to remember that there were basic foundational assumptions that were being put in there, not to over-regulate things, but keep them simple, keep them therapeutic. And I thought I should mention that. I have 3 or 4 more comments, but I just wanted to get a couple of them out there. I want to defer to others, so I think I'll go into, I'll be writing comments, okay, rather than hogging the field here. Okay.
Thank you for the comments, Joe. And could you please state your full name, just so we have that?
It's Joe Kuhn, Kuhn, CEO, BFLI.
Great, thank you so much.
Thank you.
All right, next we have Adam LaMonica.
Good morning. So my name is Adam LaMonica. I am the operations manager at Maxim Healthcare Services. Maxim is a national provider of home healthcare, home care, and additional in-home service options. We provide about 100,000 hours of service per year throughout Maine via our Portland office. We employ about 140 nurses and take care of about 75 patients a year, primarily offering private duty nursing under Section 96 and 19 of MaineCare. These are medically complex and vulnerable pediatric and adult patient populations under Medicaid. Many of you require assisted technology such as vents, trachs to sustain life. We're also a member of the Home Care and Hospice Alliance of Maine, which represents the interests of home health providers throughout the state. I'm submitting my comments today to express our appreciation that Maine's Department of Health and Human Services understands the critical need for a rate determination schedule annually for nursing services under sections 96 and 19. As it stands, Maine has utilized an outdated rate study from 2016 for current rates and has not required that reimbursement rates for home health and home care agencies be reviewed and determined annually. Improving the transparency of the Medicaid rates for PDN and other home health clinicians will help contain costs, promote better quality of life for Maine's patients and their families. These clinicians perform those highly skilled tasks in the home each day and save taxpayers hundreds of thousands of dollars each year by allowing medically fragile children and older adults to stay in their home as opposed to in a facility. Maine's reimbursement for these critical services needs to increase and be accountable to the public in order for those nurses to continue their care for their patients and perform this immense public service. The rate determination schedule will ensure that patients and clinicians' voices are heard each time the state reevaluates rates, which will provide insight into the necessary information and data that impacts provider rates and families' livelihoods. We have several patients who have waited to come home from the hospital, but due to lack of nursing availability and resources, they have to remain in that setting. This is costing the state thousands of dollars until reliable care can be accessible in the home. Having nursing care in the home gives patients, families, members the comfort of knowing that their loved ones are well cared for appropriately. Unfortunately, the lack of private duty nurses pushes the burden on hospitals who simply don't have the beds or the resources for medically fragile children and adults long term. We would like to see this problem change. Over the years, home health stakeholders have advocated for fair rate adjustments for home health nurses and caregivers that reflect current economic factors, new administrative and federal requirements, minimum wage increases, surrounding state wage increases, and other pertinent factors that have not always been taken into consideration when establishing new rates. This process has shaken agency competency, as there's no guarantee that the department will establish new rates that enable agencies to pay their clinicians the money that they deserve and need in this critical career, so that patients can remain in their homes with their families. This was especially problematic the past 3 years as a worldwide pandemic swept the country and Maine, which had our nurses working overtime around the clock, braving the pandemic, and they did not receive nearly the same hazard or incentive compensation that nurses in other industries were allotted. This rate determination schedule will allow the state to consider payment rates more consistently and to adapt to the current environment. It is our hope that this schedule will also help combat the ongoing caregiver workforce crisis and promote longevity in the home care industry by offering steady incremental increases to ensure wages will be comparable to other nursing industries. Thank you for your support for the home health care and private duty nursing services across the state under Section 19 and 96. We hope that the MaineCare Reform Expert Technical Advisory, the TAP panel, will consider the great need for transparency and accountability in the rate establishing process. Thanks.
Thank you, Adam. Next we have Eves, M. Eves. Oh, it looks like, sorry, I lost you when your hand went down.
Good morning, David. Sorry, my full name is not in the chat here. Using a borrowed computer this morning. thank you for the opportunity to provide comment. Good morning, everyone. My name is Mark Eves. I'm the Executive Director of Woodford's Family Services. We currently provide services to children, adolescents, and adults with intellectual and developmental disabilities, as well as behavioral health needs. We work with nearly 2,000 families each year in the majority of Maine's 16 counties. Today, I'll be focusing my comments on our adult services and the need for a comprehensive rate study to establish an adequate rate or a baseline to support the services provided. And I'll review the specific requests in a moment. A little bit about me before we get there. Currently, I've served on the MaineCare Advisory Committee for the past 3 years, which has been a great opportunity, and appreciate the administration starting the MAC up again in earnest. I'm also a board member of the Maine Association for Community Support Providers, also known as MACSP. MACSP is the statewide association representing more than 80 providers of services to children and adults with intellectual disabilities, autism, and brain injury. I would like to provide some initial comments on behalf of our association. We will also provide written comment as well prior to the deadline. We also deeply appreciate the commitment and deliberative efforts the department has made to create and formalize a clear and transparent process for rate setting with publicly posted and predictable opportunities for stakeholder input. The dozens of MaineCare services for the more than 5,000 adults with intellectual disabilities, autism, and brain injuries that we support largely fall under MaineCare waiver sections 13, 18, 20, 21, 29, 97 Appendix F, and Section 102. We're glad to see Section 97 Appendix F included, as well as some services under 102 included in the schedule. Dozens of Medicaid supported services that support home and community-based services, also known as HCBS, for the members with intellectual disabilities and autism spectrum disorder fall under sections specifically 21 and 29. Our request today is to ask for your support in including specific rate studies for sections 21 and 29 home supports, as well as community support services. Home supports for section 21 and 29 appear to be included, but I just heard that that might be an adjustment, and thank you, Director Probert, for that, that update. MACSP represents the majority of section 21 agency home support services, also known as group home services. And you'll hear me reference section 21 T2016, and I put that specificity in there because the confusion around section 21, the multiple services within, can be confusing, but we're referencing specifically T2016 for a rate study. We ask that a transparent, publicly noticed rate study with stakeholder input for section 21 T016 agency home support be included in this year's rate determination schedule. Group homes for adults with disabilities provide between 2 and 6 adults with 24/7 specialized support in homes in the community throughout the state. This service has not had a rate study in well over a decade. The department did increase the labor components of the rates in July of 2021 and January of 2022 as part of the quadruple A 125% legislative initiative. And we deeply appreciate this because up until July of 2021, labor components of that established rate had been nearly $1 below minimum wage at $11.22. We were not aware, however, that when the department increased the rate in 2021, that they also adopted a new rate model and methodology for the service that decreased the percentage of program costs that make up this rate. So while the labor costs technically support 125% of minimum wage, the concurrent program cut in that methodology does not adequately support the program costs, leaving providers with a rate that does not adequately support the staff and program costs for the service. The review of this rate was not publicly noticed, did not involve a new rate study, provider input, or outreach to stakeholders to review the model or methodology. This is in stark contrast to the current Burns and Associate rate setting process the department is currently engaged in with sections 13, 21, 29, 65, and 92. MACSP members provide all of these services, and we have been impressed with the data gathering from providers and the transparent process the department has engaged in. And we respectfully ask that sections 21 and 29 T016 be given the same stakeholder engagement opportunity. More than 47 group homes have closed or collapsed in the last 18 months, disrupting hundreds of MaineCare members, often uprooting them from the communities where they have built meaningful connections and lives. We anticipate another 30 closings by the end of this year. We do not believe that the determination the department conducted last year meets their previous nor current goals for transparency and stakeholder input. And we respectfully ask for sections 21 T016 to undergo a properly noticed rate review as part of the 2023 schedule. Additionally, community support services under section 21 and 29 have undergone significant rule and waiver changes following a rate determination which was conducted in 2020. The change in this rate did not involve IDD provider input, but was based on a rate study conducted for sections 18 and 20 with input solely from providers of brain injury services and services for persons with other related conditions. Again, I want to thank you for the opportunity to present today publicly. And again, we will be providing a written comment in time for the deadline. Thank you.
Thank you, Mark. And I'll just remind commenters to please keep comments to about 3 minutes. We appreciate allowing us to keep this moving along quickly to allow everybody that time to speak. We have next Leah.
Good morning. My name is Leah Gordon. I'm with Northern Light Home Care and Hospice. We are a statewide home care and hospice organization covering primarily Section 40. I'd like to echo everyone else's statements and thank you for considering adjustments for Section 40. We admit people, obviously, regardless of payer, and really provide that quality in home care based on the patient and family need. We currently have a underpayment from MaineCare of over $378,000 based on current rates. We again echo what other people have said about thanking you for looking at this. We provide not only pre but post hospital care in their homes and in patients' homes, and really, as others have mentioned, are a vital link to keeping people aging in their home. Again, I appreciate this opportunity to provide brief comments, and I'll turn it over to somebody else.
Thank you, Leah. Next, we have Angela.
Hi, good morning. Thank you, David. My name is Angela Westhoff. I'm the president and CEO of the Maine Healthcare Association. Our membership includes over 200 nursing homes and assisted living and residential care facilities, also known as PNMIs or private non-medical institutions. We also have approximately 50 associate organizational members. Our vision is that Maine provides the kind of long-term care that we would want for ourselves and our families. We listened to the October 13th meeting of the MaineCare Reform Expert Technical Advisory Panel, or the TAP. MHCA understands from the posted MaineCare proposed annual rate determination schedule that nursing homes, Section 67, and PNMIs, Section 97C, are in progress for calendar year 2023, and that a vendor RFP process is underway to assist with that rate review and rate determination process. So Public Law 2021, Chapter 639, we know that a clear and transparent process has been codified for rate determination, including the TAP and the MaineCare Advisory Committee and the Rate Reform Subcommittee. Rate reform for long-term care providers is needed. Comments during previous stakeholder meetings have noted that the current cost settlement system is overly complicated and administratively burdensome to both the state and to providers, and we agree. In addressing rate reform going forward, we would note that MaineCare is the primary payer for these services, and currently reimbursement rates do not keep pace with the cost of providing these services. In a recent review of filed MaineCare nursing facility cost reports for 2021, there was noted a $46 million shortfall between the allowable costs of providing long-term care services and MaineCare reimbursement. Facilities are struggling to make ends meet and remain open. We saw 6 facility closures over the past year, and many more long-term care facilities are at risk of closing in the future. In addition to lagging reimbursement rates, we all know that inflation is skyrocketing. Minimum wage raises every year are creating some wage compression issues throughout the workforce, and the pandemic's long shadow continues to loom over facilities. These factors are driving up the cost of providing skilled nursing care to those who need it most. As we approach the rate determination process, we encourage the department to adhere to 2 guiding principles. The first is to do no harm. The review process cannot result in a net decrease in reimbursement rates. We already have too many facilities at risk of closure and not enough capacity to address the future needs of the aging baby boomer population. System capacity is a major concern because it is currently inadequate to meet the needs of Maine's over 65 population. And that population is estimated to increase by 45% from 2018 to 2028. Secondly, we invite a robust and transparent discussion and request opportunities for provider input. The challenges facing our long-term care facilities are grave. They struggle with a workforce crisis of epic proportions. They struggle with aging facilities with no reimbursement source for upgrades or modernization, as well as ever-changing regulations and growing administrative burdens. We want to work together to reach collaborative solutions to continue to provide access to long-term care for Maine's most vulnerable citizens. This is an exciting opportunity for us to collaborate on a future for long-term care that provides best in the nation care for every resident. Thank you for this opportunity to provide comment today, and MHCA stands ready to be a partner in this process. Thank you.
Thanks, Angela. Next, we have Lori.
Hey, thanks, David, and thanks, everyone. My name is Lori Belden, and I'm using she, her pronouns, and I serve as the Executive Director of the Home Care and Hospice Alliance of Maine. You've heard from a couple of our members already, but again, I just want to reiterate that on behalf of the home care, home health care, and hospice providers across Maine, we really wish to thank Michelle Probert and the other members of the MaineCare Rate Reform Expert Technical Panel, Advisory Panel, for dedicating time and resources to such an important yet daunting work of reforming MaineCare's rate system. Again, we are very appreciative, as others have said, to seeing that nursing services under Section 19 and 96, as well as for Section 40, have been listed as a priority for calendar year 2023. Our in-home nursing services provide patients with care ranging from basic activities of daily living to more medically complex care, such as seizure management, feeding tube maintenance, medication administration, airway ventilation care, as well as a number of interventions. And those services allow patients to receive such quality care in the home as a safe and patient-preferred alternative to receiving such care in acute institutional settings. Some of our providers have made a difficult decision to terminate nursing services, and others have certainly scaled back what they can do due to lack of staffing, which the entire continuum is facing, which have attributed to their inability to retain and recruit RNs and LPNs specifically with a competitive wage and benefit package due to the lacking reimbursement rates. The average hospital RN rate of pay right now is about $36 an hour, and until recently, the recent COLA adjustment, the MaineCare reimbursement for our RN rate is only $29 an hour. So the $7 is quite a difference, and it makes it really difficult for us to recruit and retain those quality professionals in our industry. The current rates also don't account for the increased costs for benefits, as people have said, mileage, cost of living, and as well as other costs associated with implementation of electronic visit verification, background checks, none of which were anticipated when these rates were last studied in 2016. Again, we're grateful for MaineCare and the TAP that have prioritized home care clinical services in the rate determination schedule so we can be more competitive in recruiting professionals to meet the needs of patients who choose to receive care in the safety and comfort of their home. And like the others, we look forward to partnering with you moving forward to get these rates addressed. So thank you very much for this opportunity. And I too will be submitting written comment.
Thank you, Lori. Next, we have Susan.
Good morning. Thank you, David. My name is Susan White. I live in South Portland, and I am the Administrator and Director of Nursing for Core Health. We provide Section 19 and Section 96 services. I first want to express my appreciation for the decision to advance the priority of rate review for nursing services. I have been working in the home health industry for the last 13 plus years, and while home and community services have always had certain staffing issues and shortages, what we have been seeing occurring over the last few years has really been heartbreaking. We currently hold authorizations for nearly 15,000 hours per month, and we are staffing less than half of the authorized hours. In addition to that, we have another 26 clients who are in our pipeline, which represent another almost 8,000 nursing hours. Behind the hours that I'm reporting on are people who have medically fragile children. These are kids who are not able to attend school without nursing. They're parents whose lives are on hold while they wait for staffing to be found. The staffing oftentimes allows parents to hold employment, to sleep at night, and to function as near normal as is possible in situations where families often with no medical background and suddenly without warning are thrust into the role of becoming a medical provider as well as a parent. This in turn leads to increased hospitalizations, poor outcomes for these children, and the fraying of familial safety nets. Luckily, we have many nurses who are interested in home health care. Many of them are genuinely excited as they go through our interview process. However, that excitement is quickly extinguished when pay is discussed. Our rates are easily $7 to $10 less than what nurses are able to earn in other settings. And oftentimes our applicants return to us attempting to negotiate higher pay rates, expressing that they really would like to take the position, that this is potentially a dream job, the holistic capability to work one-on-one with a client. But unfortunately, our pay is just not in line, and they tend to opt for positions that will provide them and their families with a better standard of living than what we're able to offer. As of right now, for every 10 applicants that we have from our end, we're lucky to be able to hire one nurse. And rates are the #1 determining factor that applicants give us when they decline job offers. And second to that is the benefits that we're not able to offer. We have to do something as soon as possible to preserve current home health care services. Without immediate rate increases, more organizations such as ours that provide these critical resources and save so much money in comparison to other institutionalized settings are not going to be sustained. We greatly appreciate the opportunity to present our cost of doing business and to have the rates set forth urgently to be reviewed against benchmark standards. We're confident that the findings will echo our deep concerns, and we look forward to further discussions. Thank you.
Thank you, Susan. And next we have Jamie.
Yes, for MS Home Care. I'd like to thank the department for the expedited time and attention to the issue of rate reimbursement for home nursing services. This is a crucial step in meeting a growing need in our communities. With comprehensive rates, home care will be able to provide in-home care to a significantly larger client base. This rate change has the potential to decrease hospital admission and readmission rates with early interventions available. Throughout the pandemic, our pediatric department specifically saw a significant decrease in hospital admissions directly related to increased nursing care in the home. Our clients benefited from nurses that sought to leave the hospital.
I think we got disconnected, so we will move on to the next commenter, and we can revisit if she's able to get back on. So next we have Tammy.
Hi, good morning. My name is Tammy Polakowski, and I'm the nurse coordinator for Northern Maine and the infection control nurse for Core Health Services. I have also worked as a field nurse in the home caring for medically complex pediatric patients, and I spent 5 years in the school setting as a one-to-one RN. I would like to say how appreciative I am to be able to speak here today about how important it is for Section 96, which is home and community-based nursing services, to be expedited on the rate reform schedule. When deciding what to talk about today, I decided that I would focus on not the negative impact of what not having nurses brings, but I would focus on the positive impact that what it means to have nursing in the home, and that is quality, consistency, and our clients being able to stay in the home and not be hospitalized. Every client, every child, every family has their own set of circumstances. The one common thread is that they all want the best care for their loved ones. This is not something that they can always do on their own. This is where Section 96 comes into play. And it does make a huge difference in the lives of the client and their families. When given the choice, families will always choose quality of life over quantity. Home and community-based nursing services provide the opportunity for this quality. It gives the client the ability to do and enjoy things in life while being as well as they possibly can be. I'd like to share a success story about a boy who had nursing services and the impact that it had on his life. I'll refer to him as Jay. That is a fictional name. He had no services until he was 12. He was pretty much unaware of the system. But then he got a case manager and he was able to get nursing. He was able to stay in his home, and now he was able to attend school. He was also very medically fragile, suffering from cerebral palsy as a result of FAS, which is fetal alcohol syndrome. He had daily seizures and was totally unable to communicate. He would now be able to go to school. His parents would be able to attend work, and this would be the benefit from having a full-time RM. Would it put stress on his already compromised body? Absolutely. But quality over quantity was chosen, as his life expectancy was only 6 months. At school, he went to chorus, he participated in phys ed, and he was included in all classroom activities, as well as PT, OT, and speech. A child who could not communicate in any way was now using blinking motions to answer yes and no questions. And his nurse worked with him on that every single day. This was the quality of life he deserved, and it was due to him being able to have his nurse. He did pass away, but it was 5 years later, and I attribute that to him having full-time nursing services. Quality was able to give him quantity, and this is what our clients deserve. Our spot on the schedule is critical to these clients to be able to continue providing services. Home-based services have never been more important as they are now. And as Steve Jobs once said, one home run is better than two doubles. And I sincerely would like to thank all of you for taking this into consideration today.
Thank you, Tammy. Our next commenter is Paramay.
Good morning, everyone. Thank you for the opportunity for me to speak today as well. So my name is Parami. I'm a nurse coordinator from Core Health. And before that, I was also a private duty nurse in the field for 5 years, providing direct care in the patient's home. So as a private duty nurse, we provide holistic care for medically complex clients, from administering medications, free monitoring all the seizures or medical conditions, provide education to the family, accompany client to doctor appointments, school, or like all the therapies. So now I am a nurse coordinator who coordinate and oversee care plan with family and patients and provide support to staff. But every home visit remind me how much we impact our client quality of life. And one of my open in particular keeps replaying in my mind. We have a client who needs 24 hours care, but family had been unable to find staffing for over a year. And mom had to take a client to everywhere she go. He even went to like grocery store, but with the help of in-home nursing that we found later on, his medical needs were met in the home, and his nurse were able to provide like carryover therapies, and also he able to resume school in person with the help of nursing services. And so lastly, I would like to say how grateful I am for this rate review has been raised as priority, and that will help with the shortage of home care nursing staff. Thank you, everyone.
Thank you, Parami. And I will come back to Jamie now. Thank you for rejoining, and sorry your time was interrupted.
Oh, no problem. I don't know what happened. I'll just start where I left off. So now that any supplemental funds have been exhausted, many of the nurses that we did have returned to the hospital or sought employment with better compensation, leaving our clients without the excellent preventative care they so richly benefited from. In-home care has often been associated with per diem positions. A rate increase brings with it the potential to offer more full-time, long-term positions to employees, more consistent care. With the ever increasing median age of the MaineCare population, the need for services such as Section 19 provided by home care agencies increases daily. Providing fair compensations for all aspects of the sections set to be evaluated, 19, 20, 21, 40, 96, 102, ensure our elder and high needs communities continue to have consistent, exceptional nursing care. Again, we thank the department for thinking of our medically fragile community members by considering this urgent need. Thank you.
Thank you, Jamie. I do not see any other hands raised currently. So again, if you'd like to make a comment, please raise your hand. If you are a telephone user, you can do that by pressing *9 on the keypad of your phone right now. And we'll give it a minute or two to see if any more hands are raised, and we look forward to your comments. And just as a reminder, while we're waiting for additional comments, if you would like to submit your comments in writing, those can go to Amanda Lee. So that is amanda.lee@maine.gov, and she will be aggregating those written comments. All right, well, seeing as no more hands are being raised, I will thank you all for your time. Thank you for joining us today, and we appreciate all of the comments that you have submitted. And we will be following up in a couple of weeks to close the comment period. And then a few more weeks after that, we will be summarizing those comments and posting those online. Thank you all again for your time, and we look forward to receiving your written comments. Have a great day, everybody, and we'll hear from you soon.